accept our apology. And it's my pleasure to introduce the first presentation to be by Professor Dr. Tyler Hughes, the Dean of the Medical School in Kansas University, USA, and the first Vice President of the American College of Surgeons. It's our pleasure to have him among us in Egypt. It's his first time in Egypt, and I wish he will have a nice stay with us, and you will have a good impression about our activities in surgery and academic activities. So please, Dr. Tyler, you will have the first presentation. He will give us the presentation about the importance of rural surgery in a specialized world.
Thank you, Dr. Mott. Good morning. It is an extreme honor and privilege to be with you today, a place I've dreamed of visiting all my life. I think we have much in common, even though we live on opposite sides of the globe. So thank you so much for the honor of this invitation. As we began to prepare for my visit, we discussed what topics it might discuss, and I brought up rural surgery, which is sort of what I'm known for in the United States, but it's a concept that's just now evolving throughout the world. We're big on disclosures at the American College of Surgeons, so I must tell you that I have a paid position with the ACS Communities, which is our social media platform, which I hope many of you read. We have international communities as well as those in every specialty. However, it's free with your membership, so I won't be selling you anything about the communities today. So as I said, when I got the invitation to come to Egypt, I thought, how different could we be? On the left is where I live, in the wheat fields of Kansas. And there are just about as many people in Kansas as you see in this slide. We're a low population state, less than 3 million people. And of course on the right, you recognize your home of Giza and the Great Pyramids. And the differences are quite profound. This is on the left, the main street of the town where my medical school campus is, in Salina, Kansas, which is only 50,000 people live in that town. We serve an area of about 100 to 150,000 people. And on the right, you obviously recognize Cairo. There seems to be somewhat difference in scale here. I think Cairo is just a little bit bigger. So it's been quite amazing to see the scale of literally everything from medicine to history here. So what is rural surgery? Sometimes to see something small, you need to step back. So I've used this picture for many years. It's obviously a very wide angle of the earth at night, taken at night, which has always confused me because how they get the whole earth to be dark at the same time, I think it's been photoshopped. But where you see light is not where rural surgery is. Rural surgery is in the areas that are dark, that have less resources. And if you look at the United States there, you can see sort of a dividing line. The eastern half of the United States, many, many lights. The western half, very much less until you get to the West Coast. You see that in South America, certainly in the continent of Africa, although there's some very bright lights around Cairo, and throughout the rest of the world. If you look in the right side of the slide, that's Australia, New Zealand, and the Southern Pacific, which contain millions of people, but very, very far apart. But it's not just geographic distance. It may depend on distance because if you're 400 kilometers away from the nearest medical facility, you're always 400 miles away. It's not like there are rush hours where it's slower or faster. You're always that distance away. But there also may be mountains, deserts, other geographic obstructions that prevent the rapid transfer of patients from one place to another. And weather plays a big part. My friend Mike Syrup in southern Ohio once had to treat primary aortic injury along with multiple abdominal injuries in a young woman because there was a blizzard. There was no ground transportation, no air transportation. This patient was dying, and so he had to take this woman to the operating room to save her life, which he did, and she subsequently has grandchildren, which Dr. Syrup treats. And the other thing is resources. In my travels around the world, I've found that even in high-density populations, there are low resources, not enough technology or infrastructure for the amount of people there. I certainly saw that in Thailand when I visited there, New Zealand, and Scotland. So there's a commonality in all of these places across the world. People need surgery, and the technology and infrastructure is not there. And who is the prime force surgically? It is the general surgeon, the generalist, along with his family practice cohort and anesthetist. And as I said, having traveled the world in all these beautiful but remote places, there is a need but not surgery. L.D. Brett is one of our past presidents of the American College of Surgeons. I know there are concerns about doing surgery in remote and low resource places, but the fact remains, if there's no access to care, there is no quality. So first we must have access, and that is what rural surgery is about, providing access. So here are 4 cases that I saw during my practice in McPherson, Kansas, a town of 13,000. A fungating breast carcinoma who actually presented after a motor vehicle accident. She had had this cancer growing for years and had hidden it, did not have access to treatment, and resulted in such profound anemia that she passed out and had a car wreck. So doing our classic ATLS protocol, course E of ABCDE is exposure. We threw this back and suddenly knew we had a much bigger problem. I instantly became a surgical oncologist at that moment. On the upper right is a stingray bite. Kansas is at least 800 miles from any ocean. This patient had been stung by a stingray in Florida, thought that was a bad thing, immediately got on an airplane to come see his surgeon in McPherson, Kansas, who, of course, had never seen a stingray bite. So I called the guy in Florida that I knew, and he told me how to take care of it. Even relatively minor injuries like the scalping injury on the lower left is the province of a general surgeon to save a life. This patient was literally bleeding to death from the scalp injury. All it took was the surgical recognition that we had to stop that bleeding now. We cleaned that wound up, and she did very well. And finally, there's a Bezor, a pilo-Bezor from a young lady who was ingesting hair and developed a gastric outlet obstruction. So this is the breadth and variety that you may see in a small town, and there are no specialists around to assist you. Recently, excuse me, I need to move this just a bit. we've been talking about rural surgery more and more internationally, and here's the why of it. 40% of the world's population lives in what can be considered a rural environment. Mortality from trauma is actually 5 times greater in rural locations. But the rural population isn't just small, it's critically important. It's where we get the majority of our food, energy, and raw materials that make urban life possible. Rural surgical care is an economic engine for smaller places that allows them to grow into larger places. Without medical care, industry and commerce do not come to a small place. In the United States, our theoretic ideal surgeons per 100,000 is 7.5. The latest data I have is from 2019. Our urban population has a 5.4 to 100,000 and rural 3.1. So obviously there's already a shortage both in urban and rural surgeons. Focusing on the United States, there are 56 million people who live in rural locations in the United States, and 13.4 million of them are children, which adds another level of complexity of their surgical care. The United States has about 5,000 hospitals. 1,200 of them are rural hospitals. 600 of those rural hospitals are facing closure because of economic reasons in the reimbursement scheme, as well as a dearth of practitioners, clinicians who live there. 1/2 to 1/3 of the surgical workforce in the United States is within retirement age. Dr. Ellison, who visited you last year, estimates that the U.S. alone will be 30,000 surgeons short by 2030. So there is already a crisis in surgical access in rural America, and a bigger one coming in urban America. I suspect similar issues are true across the globe. Now, I don't mean to say that specialists don't have a place, not at all. They deliver highly complex care for unusual conditions, and they also provide teamwork, complex surgery for fairly common procedures such as heart disease and valvular disease. So my theory is that we need a generalist to do a broad swath and a generalist to recognize when you need these complex instruments in order to make your patient well. The reason that I find it particularly important is the critical nature of delay in care. If a patient does not have access to what I call surgical cognition, the recognition that this patient needs surgery or needs complex surgery, then care is delayed. And it is a truism that delaying care causes poorer and more expensive results. The training of a rural surgeon needs to broaden our scope and balance general surgery with specialty care in a more coordinated fashion. It is not appropriate and possible to simply transfer these patients to a tertiary or quaternary facility, mainly because of delay, reimbursement, and capacity of the tertiary and quaternary services to be able to absorb all of those patients. The Lancet Commission instituted a study of global health, which is essentially rural health, and included surgery as an essential healthcare need. It was actually, I think, 2011 that surgery was included by the WHO as an essential part of medicine, which absolutely astounds me, considering that surgery has been a primary treatment since the days of the pharaohs, and why we didn't recognize surgery as a primary need is somewhat puzzling to me. This means 5 billion people are in need of surgical access across the world. And it's estimated that every year 12.5 trillion with a T dollars are lost in productivity of patients who are disabled or die secondary to lack of surgical access. That means that the investment in surgical care in both large and small places saves lives, induces economic development, and is affordable. It is cost effective. I got some data when I was attending the Board of Regents meeting last February. I already mentioned about the 5-fold increase in mortality for rural patients. 40% of rural patients are more likely to die in the first 24 hours after trauma, and 24% of all trauma deaths are childhood traumas. 40% of rural patients receive care in a trauma center versus 90% for urban patients. Delay in trauma care is frequently occurs. Where you live, therefore, may determine where you will die when it comes to surgical care. As I said, this is not a problem localized to the United States. It's worldwide, and this map shows how extensive the problem is in terms of geography and patients. In the United States, the factors that are affecting this problem, we all know medical education is expensive and it takes a long time to create a surgeon. Technological advances have outpaced distribution of those technologies. Reimbursement for specialty care is higher than it is for generalist care. This is particularly true in the United States, and it attracts trainees to more specialized care at the expense of the need across the nation for general surgeons. There are maldistributions because of economic and sociologic factors, which I'll talk about, and admission policies in medical schools and residency tend to be prejudiced toward accepting urban individuals. There's a gap between what is needed and what we train for. These are some of the countries, that all of which confirm my suspicions that this is an international problem. So how do we build up a rural force? First, we need to change the admission policies to take into account what the needs are. Use demographic analysis to define the areas and types of procedures within a country, and then plan based on those demographics. Change the training programs to support truly broad-based surgical care and make it a specialty just like plastics, colorectal, or vascular surgery. We need to create funding mechanisms to achieve parity between rural and urban environments. What were I meaning by changing admission policies? I think we need to focus on the place of origin of students, because sociologically those are the most likely to return to a rural environment. And maybe we should refrain from the practice of admitting the best test takers and saying that that equals the best possible doctor. So a small, practically microscopic example is the school that I'm honored to work with. We were founded on the principles of supporting rural health. We only take 8 students per year. Remember, we're a very small state. We don't need to create 200 or 300 rural surgeons per year to solve the problem. 88% of our students are residents of Kansas. Most of them are from towns less than 50,000. I have one student who's from a town of 70. During the 8 years of our experience, we've graduated 63 students. 72% of them went into primary care and 30% into specialties, including general surgery. And those out of residency, 63% are practicing in rural towns. So this is a map of where all of our students went to residency. As you can see, It's like a shotgun blast all over the United States. They went everywhere. When they finished residency, look where they came. Right back to where they grew up and first trained. Excuse me. So we need to identify the demographics of population change, because we are seeing a shift in the populations in many countries, and match that growth and training so that we can fulfill the needs. I think we ought to have a specialty of rural surgery. It needs to have an expanded scope of practice. We need to expose students and trainees to rural environments so they can see that excellent surgery can be done in low resource areas. We need to give special recognition for the abilities and the documentation to provide those. Funding, well, it's not about the money, except it's about the money. How do we do that? And good, I was at my summary slide. So it's a moral imperative to take care of these vast populations in distant areas. It will improve their economics and improve the economic of a country overall. We can't parachute just a single surgeon in. We need to develop whole surgical teams. And in low and middle income countries, rural surgical care shares many of the same challenges as in high income countries. All of this is possible, but first we have to be aware of the problem, focus on practical approaches, and the involvement of all the surgeons, governments, and people of the communities to be successful. These are a few references. I particularly would point you to the surgical clinics of North America to find more data. And so thank you from my small medical school in Kansas, and I hope you have a wonderful conference.
Thank you so much, Dr. Taylor. This is a very interesting, I'm here. Interesting overview for the problems of surgery in rural areas. And I liked your definition of the rural areas. But if you allow me to add to it, the ships in the middle of the sea. Whatever the ship is luxurious, it is rural. If emergency happens. So I think it is also, it could be added to the rural surgery. You concentrated on the problem of the presence, the number of the surgeons, the training of the surgeons, the resources. But the problem is not only in the surgeon, but with the team working with the surgeons, the anesthesiologists, the nursing. It has the same problem in the rural areas as the surgeon. So the training and the movement of the skilled persons from urban to rural areas of the whole team is essential, as well as the surgeon. Also in the rural areas, the problem of transporting the patient to a tertiary hospital if it is needed. So what do you think?
Well, I think you're absolutely right. As a surgeon, I tend to concentrate on surgeons, but at our campus, we also have a nursing school, and we select nursing students from rural populations. So we're having some success with that. We hope to, in the future, have an entire allied health school there for anesthesia, physical therapy, and the other ancillary services you need. I think in order to achieve all this, that we need governmental and community support, because the money is not there in a tiny town to do that by themselves. But if we can see that it's a state and national problem and work in a coordinated fashion, sort of like we do with trauma, I think we'll have much more success.
Any comment? Thank you so much. We'll move to our next speaker, Professor Ahmad Ali, Professor of Surgery at Shams University, and he will speak about the experience of Shams University in robotic colorectal surgery.
مش دي بتاعتي. كده وكده. طب الفيديو لو عايز اجريه. هي مش تاتش صح؟ دي مش تاتش. لا عشان الفيديو لو عايز اجري الفيديو. فين البرزنتيشن؟ فين البرزنتيشن؟ لا مش هي دي. احمد علي. مش هي دي. احنا في سيشن امريكان كولج اوف سيرجنز. مش دي اللي قبلها. استنى هو حاططها غلط. لا ده حطها غلط يا دكتور محي من بره الظهر. طيب طب دكتور حسن ممكن نشفته على ما اصلح الموضوع ده؟ اه تمام.
So while we load the next slides, we'll move on to Dr. Akali in the evaluation and management of trauma. He's the director of Egyptian Life Support here, and I look forward to his presentation.
Good morning. It's really my pleasure to be with you today. I would like first to thank Professor Mohi al-Banna for giving me this chance to be with you. And it's my honor to be a fellow for American College of Surgeons since 2012. And now I'm the chief of Region 17, Committee on Trauma. And also I would like to welcome Dr. Taylor in Egypt. Welcome. Today I just give an overview about the management of trauma patient and the initial assessment and how we are managing a trauma patient according to the ATLS guidelines. I have nothing to disclose. So the objectives for my discussion with you today will be about the primary and secondary surveys to the assessment of a multiply injured patients. The patient's medical history and mechanism of injury contribute to the identification of injuries. Recognize patients who require transfer for definitive management. And this is simply the algorithm we are following when we are managing a trauma patient. So we are starting first with the primary survey, but always remember before we go to the primary survey, we start with the preparation. And in a while we speak about the preparation because it's very important. Then we'll go to the primary survey, EBCDE, re-evaluation, which is very important. And after we finish the primary survey, we'll go to a second survey, then definitive care and re-evaluation. If we start first with the preparation, so I start by preparing myself, and when we are speaking about preparation, we are considering the full standard precautions, full PPE, the cap, the gown, the gloves, the mask, the shoe, protective eye cover. This is very important when we are dealing with the trauma patients. Then after that, we'll prepare the scene, prepare the team, prepare the equipment. The equipment should be ready and working. Then we go to the primary survey when we receive the patient. We're starting with the airway, A, with C-spine restricted motion, B, breathing and ventilation, B, circulation with hemorrhage control, D, disability, neurostatus, E, exposure and environmental control. I just want to remind you when we are dealing with a trauma patient, it's not it's only a sequence, but it's a teamwork approach. So as you see in the picture, so a team dealing with the trauma patient. So primary survey and resuscitation of vital functions are done simultaneously using the team approach. And this is very important. Starting with the airway and managing the airway, establishing a patent airway. All the time we have to remember a protected C-spine. Then after that, after securing the airway, we'll go to the B, breathing and ventilation. And in this case, we should consider the respiratory rate for the patient, chest movement, air entry, and oxygen saturation. After securing the B, we'll go to the C. And in the C, we'll see the level of consciousness, the skin color and temperature, the pulse rate, and character. We have to make sure of the good organ perfusion. The disability, and in the disability we are looking to the baseline neurologic evaluation, GCS for the patient, including the eye, the verbal, the motor, and pupillary response. Then after that, the exposure, and when we are speaking about the exposure, we have to remember that it's very important to expose the patient totally, to see what you cannot see, like a wound, an injury which is not clear and it's not apparent for the patient. Don't forget that what you can see from the patient, the front is only 50%. So you have to log roll the patient and to check the back. Don't forget to prevent hypothermia by good covering for the patient. The adjuncts, remember that the adjuncts we are doing it, you do it all through, you are going through the primary survey for the patient. So when you are checking the B, you are attached the pulse oximeter for the patient. When you go to the C, you would draw the blood from the patient, you will do the ABG, you'll take the vital signs, the ECG for the patient, the pulse oximeter. Don't forget your cath, which reflects the tissue perfusion, and oral tube or nasogastric or orogastric tube. From important adjuncts also is the chest X-ray, and during the course of ATLS, we have a very good discussion with the candidate how to read the X-ray in a systematic way, rather than to look to the X-ray and tell the abnormality, but we are training them how he will go in a systematic approach for reading the chest X-ray, because it is very important to be trained how to read it in a systematic way, and also the pelvic X-ray, which is from the adjuncts of the primary survey, and is very, very important. From the adjuncts of the primary survey is the fast focused assessment, sonography for trauma patient, and with the 10th edition, We have an adjunct station, and we are training the candidate about the FAST. We are bringing the FAST machine. We are bringing a patient or a volunteer, and we are training the candidate how he can use the FAST in a simple way and how it's very important during assessing a trauma patient. Also, the DBL, diagnostic peritoneal lavage, to check if the patient has any abdominal injury and bleeding. Transfer. Transfer is very important for the trauma patient, especially that in most of our situations, we are not working in a trauma center. Usually, you are working in a small hospital or even in the periphery. So, actually, we have a good discussion with the candidate during the primary survey that he can start to think about transferring the patient even before he will see the patient. If he got the call and he can assess from this call that the patient is beyond the capability, beyond his capability, he has to start the initiation of the transfer. But he has to accept the patient, start the primary survey, stabilize the patient, and after stabilizing the patient, you can go with the transferring the patient to the definitive care or to trauma center. One very important message we need to remember all the time: don't delay transfer for diagnostic tests. After finishing the primary survey, we go to the second survey. So in the second survey, okay, so we are doing the second survey after completing the primary survey, and you are happy about the vital signs for the patient going back to the normal. So completing the primary survey, assessing the ABCD properly, vital functions are returning to normal. This is the time to go to the secondary survey and assess the second survey for the patient. Secondary survey components, the history, and it's very simple. You are saying it's an ample history, the allergy, the medication, past medical history, last meal, and event. Quick history for the patient, head-to-toe examination, complete neurologic exam, a special diagnostic test, and re-evaluation. And this is a very important point. Keep on re-evaluating a trauma patient. So the history, starting by the ample history, allergy, medications, past medical history, pregnancy for the lady, last meal, event, and environment mechanism of the injury. Here I just want to stress on the mechanism of the injury, because we are discussing with our colleagues in the ATLS that when you know the mechanism of the injury, this might help you to know where is the injury the patient might have. And it's very important when you are assessing a trauma patient to know the mechanism of the injury, which will help you a lot. Starting with the head, you look to the external exam. If you find any wound, the scalp and palpation of the scalp. You look to the eye, you look to the ear, you look to the maxilla, you look to the mandible. Visual acuity, this is very important. So it's full examination for the head, the maxillofacial, the bony crevitus, deformity, malocclusion. Then you'll go to the neck. It's very important to look to the neck from the mechanism of the injury. Again, it will help you what could be the abnormality. So if you look at the picture, it seems that there is something was hanging the neck of the patient. You look to the trachea, is it central? You assess the palpation of the carotid arteries bilaterally. In the chest by inspection, if you look to this picture, yes, the seat belt is very important. And all of us, we are, and even when you are in your car, the seat belt is very important. But don't forget, when you are assessing a trauma patient, that the seat belt can do this sign, as you see the sign on the chest. So by inspection, you look to the chest, you palpate to see if there is any abnormality or any tenderness. You percuss to see if there is dullness or hyperresonance, suggesting of pneumothorax. Auscultation is very important for all areas of the chest. X-ray is very important. After that, you go to the abdomen by inspection, auscultation, then you go to the palpation and re-evaluation all the time. Perineum is very important to check for contusions, hematoma, laceration, urethral blood, look to the rectum. Sphincter tone is very important, but don't forget to take a consent, a verbal consent from the patient if he is awake and can talk, because this is very important. Listen to the, you check the sphincter tone, because if it's lost, this is suggestive of neurogenic or spinal shock. If it's a lady, check the vagina and do vaginal examination for the bleeding or laceration. Extremis, again, is very important to find the contusion, deformity, pain. Check the perfusion and the distal pulsations, peripheral neurovascular status, X-ray as needed if there is any deformity suggestive for a fracture. In the brain, check the GCS for the patient, pupil size, lateralizing signs, frequent re-evaluation, prevent secondary brain injury by preventing the hypotension and the hypoxia for the patient. So good monitoring for a trauma patient is very important. A special assessment or spinal assessment, the whole spine, if there is any tenderness, any swelling, complete motor and sensory exam, the reflexes and imaging studies. Here they are doing a log roll for the patient, checking the back. You can remove the board after checking the back for the patient. This is what we call the log roll for the patient, which is very important for the trauma patient. Total immobilization for the patient is very, very important to keep the patient totally immobilized. And this is how we are immobilizing a trauma patient. Not only putting the C-collar for the patient, but total immobilization for the patient on the board. One important test for the secondary survey is the CT, but I want to remind you that we are sending a CT, we are sending the patient to the CT when the patient is stabilized, when the patient is stable. I can send the patient to the CT while the patient is not stable. It's very helpful for the trauma patient to do the CT for them. Pain management is very important to relieve the pain and anxiety and should be administered intravenously. Transfer, as we said, if the capability exceed the capability in multiply injured patients, you need to transfer the patient when the patient is stable. So in summary, this slide will summarize what we are doing for a trauma patient. Again, primary survey, before the primary survey preparation, prepare yourself, prepare equipment, prepare your team, keep on re-evaluating the patient. Don't forget the adjuncts. After stabilizing the primary survey for the patient, go to second survey. Again, re-evaluation is very important, and the adjunct for second survey is the CT. Again, I want to remind you, we are doing a CT when the patient is stabilized. Then finally, definitive care, either the patient will go to OR, to ICU, so we have to decide and keep on re-evaluating the patient. Thank you very much, and thank you for giving me this chance.
Thanks so much, Professor Kohli. Any question, any comment? Thank you so much. We'll move back to the lecture of Dr. Ahmed Ali. I hope this time the presentation is the right one.
هم لسه بيفتحوا. ايوه هي دي. اللي فاتت مش دي. ايوه. Okay. Finally, the presentation is here. So it's my pleasure to present in front of you today in our annual Congress. And thank you, Dr. Hassan Shaker and Dr. Muhi Banna for giving me this chance. I'll give a short presentation about robotic colorectal surgery, Ain Shams initial experience. You all know that we established the robotic platform in Ain Shams University Hospitals, and we are the first university hospital to establish it in Egypt. We have this pleasure, and we are sharing our experience about colorectal surgery with you today. So first of all, I'll give an overview, history overview. مش شغال البوينتر. A historical overview of about robotics. The word robot comes from the Czech noun robota, which means hard work. Throughout history, there was the idea of manufacturing self-operating machines to do certain and specific tasks, whether under human supervision or not, has been present throughout history, and there are many models of robotic machines, of course primitive types, in different civilizations. By the emergence of the 20th century, the technology and surgical innovations have been introduced in all the fields of life. And of course, surgery is one of the most important fields that are affected by the surgical inventions, machines, and technology. In 1985, Co reported the first use of robotics in surgery, and that was stereotactic brain biopsy through a primitive model of robotics. Then the true emergence of robotics in the surgical field, the idea came when the NASA and Stanford Research Institute collaborated about this idea to perform a robotic platform, and the primary idea was to do, they had the idea of doing tele manipulation and remote surgeries, remote sophisticated surgeries for the soldiers in the battlefields and in space. Actually, this is not performed nowadays, but that was the idea of performing the robotic systems at that time. And I think, and I believe, in the future, this will happen. Then, Intuitive Surgical Company, which is the leader in manufacturers of robotic platforms, in 1997 invented the first prototype of the surgical robots, which is called the Da Vinci surgical robot. And of course, all of you know that Da Vinci is the most advanced and the most spreadable type of robots all over the world. And in surgery, as we know, that when you have a new idea or a new concept that is introduced in surgery, it spreads virally. So many centers adopted this platform, robots, and many surgeons were enthusiastic about performing their surgeries through robots, and that's why it became booming. Since the early 2000s until now, a lot of literature was written about robotic surgeries in all surgical fields. Of course, one of them and one of the most important fields of surgery that robots were introduced in was the colorectal surgery. Weber in 2002 reported the first robotic assisted colectomy for sigmoid diverticulitis. Then Hashi Zoom performed the first robotic colonic resection for cancer, and then that spread throughout years. All this literature was found in the early 2000s, as you see. All that happened together, and this emphasizes the idea that all the surgeons look at each other and they want to have the initiative. Giulianotti performed the first series of anterior section for rectal cancer, and now the robotic surgery is established program in many centers all over the world, especially in the developed world, USA, Canada, in Asia, and finally you have it in Egypt. In 2021, we got the robotic system by Cambridge Medical Robotics, which is another company different from Intuitive. Now there is a lot of companies which are manufacturing robotic platforms with different concepts and different strategies. We got in Ain Shams University Hospital the robotic system by Cambridge Medical Robotics, which is called Versius system, and it's different from the Da Vinci platform in many concepts we will show in the presentation. First of all, it's composed of the main console, the surgeon's console, which is presented now. And the console is different from the Da Vinci mainly in that it's open console. It's not closed like Da Vinci. So you have an open screen, wide screen, with 3D vision that you can see the whole operation and perform it through 3D vision by special goggles. Also, this console is completely adjustable. The surgeon can perform operation while sitting or standing, whatever he wants, according to his comfort. And this emphasizes the ergonomics of the operating surgeon. And then the working instruments are loaded on bedside units. You have 4 bedside units, 1 for the camera and 3 for working instruments. And it can be extended to another bedside unit to be 4 working instruments. But commonly, we use 3 working instruments in addition to the visual port. And bedside units have arms that the robotic instruments are loaded on these arms, and as we see, the arm mimics the human arm. It has 3 joints like the human arm, exactly, the elbow and the shoulder, elbow and wrist. So this gives free motion for the instrument inside the abdomen, and the instrument itself can rotate 330 degrees. It can give full range of motion exactly like the human hand, but it has the advantage of being more precise and very small, so you don't need to do open wounds in order to perform your operation. In Ain Shams University, in Ain Shams Specialized Hospital, we performed to date 15 robotic colorectal procedures, and actually this is not a big number because the program was interrupted in the middle of 2022 until December 2023 for some technical and financial issues, and then we restarted our program again. So now we have 15 robotic colorectal procedures. We had 4 suture rectopexies for rectal prolapse, 2 APR procedures for low rectal cancer, 5 sigmoid resections for sigmoid cancer and diverticular disease, and 4 anterior sections. And we had the pleasure that we performed the first robotic suture rectopexy in the world in Ain Shams University Hospital by the Cambridge Medical Robotics System. So there are many differences between robotics and laparoscopy, and I will show in a later slide. But one of the most important things is the docking time, which is the time you apply the robotic arms and the visual port into the ports inside the abdomen in order to start to perform the operation. And this must be planned and must be designed carefully, because we don't have the pleasure of changing the operating table while performing robotic surgery. So you have to fix the patient, put him in position, and then dock the arms into the ports, and then you start doing the operation. And this short video shows how the bedside units and instruments are working, and the surgeon is sitting at the console controlling on these arms. The operative time, of course, it was longer, and then it starts by time to decrease. The docking time and the surgical performance itself becomes less by increasing the number of patients. So we have an average time of 3 hours for the rectopexy, 4 hours for sigmoids, and 5 hours for APR and low anterior section. This is a short video clip showing how the instruments work inside the abdomen, and I want you to see mainly the immersive and very clear and defined view of the anatomy. So you can see the fine details of the tissues. You can see how pneumoperitoneum works and dissects into the tissues, and you can see the fine details of the anatomy into the abdomen. When you see the instruments working, you will see that it can rotate, and it can have full range of motion, which is different from laparoscopic instruments which have only to and fro back and through movements, and you can work using traction. We use traction in laparoscopic procedures, while in robotics, we don't depend on traction, we depend on the range of motion of the instruments and the immersive view, which can show you the fine details of the anatomy. I will run the video. So, the advantages of robotics. What's better in robotics than in laparoscopy? You perform the procedure through ports exactly like in laparoscopy, but what's the added benefit of robotics over laparoscopy? First, the better ergonomics. The doctor or the surgeon, the working surgeon, sits and can perform the operation without scrubbing and at his extreme comfort. No need for muscle strain, exactly, or that's what happens with laparoscopy, especially in prolonged procedures. Also, and this is the most important advantage of robotics over laparoscopy, which is the stable, completely controllable view, immersive 3D vision that the surgeon can see and through which the surgeon performs the operation. Also, the dexterity and the ambidextrous capabilities of the working instruments. As I said, they can go deep into the pelvis or in the narrow spaces, perform very meticulous and precise surgical procedure without any extra effort using muscles or using strain over the surgeon. And as I said, it's more evident in narrow spaces, especially in narrow male pelvis for pelvic surgery, and that's why the most specialty using robotic systems is urology. Next is gynecology and colorectal. However, as any type of technology, we have advantages and we have limitations. The limitations regarding robotic systems include it's time consuming, it's more time consuming than laparoscopy, it's more sophisticated, a lot of details regarding training, regarding operating the robotic system itself, docking, how it works, how to prevent instrument clashing, which is not in our mind using laparoscopy. You can clash instruments, no problem, but in robotics, if you have instrument clashing, the operation will stop, and then you have to redock or you have to correct what happened. The lack of haptic feedback and tactile feedback, which is very important in surgery. However, in robotics, you don't have this, but you can overcome it. I will show you how. And of course, it's highly expensive as any new technology. It has a lot of costs. Consumables and instruments are expensive, and the whole program is more expensive than in laparoscopy. Also, in our platform, we have lack of some important instruments like staplers, energy devices, and clips. They are not established in this platform, but it's now available in other platforms like Da Vinci. But what I want to say that all these limitations are reversible by increasing the training and by increasing the number and volume of cases. When you increase the volume of cases, you will learn how to reduce the time, you learn how to synchronize the work of the instruments to prevent clashing and to perform all the procedure easily, and then you will find that the expenses will drop, because by time and by experience you can ignore the use of some important devices and some expensive consumables like staplers. You can do hand sewing or robotic sewing anastomosis instead of staplers, for example. You can ignore the use of energy devices and use bipolar and monopolar by robotic dissection. So the most important different items between robotics and laparoscopy is, first, we have different port positions for performing different procedures. They are not the same. According to the procedure, you plan your port positions. Of course, we have the improved, magnified, immersive 3D vision, which is the main point of strength in robotics, and which helps you to depend on the art of dissection rather than traction. In laparoscopy, sometimes we use the traction and we use the hand force in order to dissect and in order to get into the anatomical plane. But in robotics, you have to change your mindset to make it depending on the art of dissection and to identify the anatomy without using extra effort. Also, you have to plan to work in different abdominal compartments, because changing the abdominal compartment means that you have to redock and reposition your ports and your instruments in order to perform this operation. And finally, you have to synchronize during the instrument handling. This needs some training for the surgeon in order to change his concept and change his mindset from using laparoscopy and robotics. Finally, our initial experience with robotic platforms in colorectal surgery is promising, safe, and feasible. And with increasing the number of operations and cases, we're gaining more experience, and we will be able to clearly demonstrate its value and take full advantage of this important technological milestone. Thank you.
Thank you so much, Dr. Ahmed. You mentioned a very crucial point in the limitations of robotic surgery in the CMR system, I mean, which is the use of the energy and the staplers. Will you tell us, in the cases you have done in our hospital, how did you overcome the two problems? Because using the unipolar or bipolar for control of bleeding and sealing of the blood vessels is not enough, because it is not enough for sealing, especially large vessels. It needs either a good energy device or the clips. And you don't have the luxury of the clips, the energy, or the staplers. So in your experience, what did you do to overcome this?
Thank you, Dr. Hassan. It's a very important question. And the answer is we use laparoscopic assisted robotic procedures. So we always have an assistant port so that we introduce the lacking instruments through laparoscopic port, and we do it. For example, when you skeletonize the inferior mesenteric artery, we put clips by laparoscopic clip. We use the laparoscopic staplers.
So is it possible to do it combined?
Yes. We always have this.
I have a question. What was the training like prior to actually operating on a human being? How long did that take? How intuitive, if you'll pardon the expression, was that process? Is it a huge jump from laparoscopy to robotics, or a small jump?
No, it's not a huge jump, because in my opinion, when you do laparoscopic surgery, you can do robotic surgery easily. All what you need is to change your mindset and to learn how to use the robotic platform. That's all, but you don't have change in the laparoscopic anatomy. The only difference, you have to know the laparoscopic anatomy very carefully and very well. So when you know the laparoscopic anatomy, for example, for laparoscopic hernia repair or cholecystectomy or colectomy, whatever, I know what I'm going to do. I know the laparoscopic anatomy, I know the view. All what I need to do is to train myself to use the robotic instruments with its concept, which is different from laparoscopy, but the same surgical technique, the same view. All what I need to do is to train myself to use the robotic instruments and the robotic platform. So, in my opinion, the training depends on changing my mindset to use the full movement of robotic arms and robotic instruments, and to get the same procedure using these instruments. So it takes some time. It's not that easy, because the synchronization, especially when I change from one compartment or one view to another, it needs some sort of synchronization between the instruments and the camera in order not to clash, for example. And the way of handling, the way of using the electrocautery, all of them are managed through one hand. So that's all about the training. When you are doing this comfortably, you will do the operation very easily.
I think the best indication is in your field, the colorectal surgery, is the deep pelvic lesions,
Exactly.
namely the lower rectum, for example.
Exactly.
For the abdominal surgery, for sigmoid or left colon, I think it equalizes the benefits of laparoscopic surgery.
Exactly. Exactly.
Yes, Dr. Hassan. He's Dr. Hassan Sheikh.
Of course.
Okay. And he's urologist. Please, I want all in the room to know that, because all his patients come to me first.
So, as Dr. Hassan said, I'm the other Hassan Shakir. And I have a deal with Dr. Hassan Shakir, the original Dr. Hassan Shakir, that we should send each of us, others patient to the other surgeon. But anyway, I enjoyed very much over the last 30 years of my patients coming from you first. So I'm sure that they have no general surgical problem. Anyway, so your question is very important, actually, Dr. Taylor, about the training and the shift from either open surgery to robotics and laparoscopy to robotics. Although in the literature there shouldn't be a difference in that jump, but what we have seen that there is actually a big difference. It's whenever you are a laparoscopic surgeon, it's much easier to jump to robotics. And as Dr. Ahmed said, you just need to change your mindset. You need to do some sessions actually of dry lab and simulation and maybe the basic training, and that's it. It's not that big deal. But you have to change your mindset. You have to synchronize very well with your assistant, because you depend very much on the assistant to do many of the steps that you used to do in the laparoscopy. For example, staplers, the use of advanced energy, and so on. We adopted something a little bit different in urology, and we think it saves so much time, which is some sort of hybrid techniques. For example, we did last week robotic assisted partial nephrectomy, and there is no point actually to do all the initial dissection and coherization and skeletonization of the vessels with the robot. There's no advantage here. You actually lose much time doing that with it's much faster with the laparoscopy. And then the step that you need the robot in would be the excision of the tumor, because whenever you have like a complex tumor, you need to go, you need to attain certain angles that you cannot do with the normal laparoscopy, and of course in the suturing. It has a major advantage of suture. But the drawback here in partial nephrectomy, because you have a very limited time of hot ischemia or warm ischemia, you need to synchronize very well with your assistant, because he will be putting clips for you. He will be putting the bulldogs on the vessels. So synchronization again with the assistant is a major step that we all have to learn to get the advantage of robot surgery. Thank you very much.
Thank you so much for this very valuable comment. And Professor Hassan has an large experience in the urological robotic surgery, so he is in the depth of the technique. Any other comment? Thank you so much.
Thank you.
So we'll move to Professor Mohi El-Banna. He's a professor and the head of the Department of Surgery at Shams University. My dear brother, and he will speak about the changes in initiation of healthcare institution.
Thank you very much for the introduction. My professor, Professor Hassan Shakir, President of the Egyptian Society of Laparoscopic Surgeons and past head of the Department of General Surgery at Shams University. We are pleased to have Professor Tyler Hughes, Vice President of the American College of Surgeons and Dean of the Kansas University School of Medicine. Thank you for coming. It's an honor to have you in Egypt and in our conference. Your presence is enriching our conference and our conversation. And it's great to have both Professors Hassan Shakir in the same hall. Actually, I was asked a few days ago, who's the chairman of the session, Professor Hassan Shakir of General Surgery or Professor Hassan Shakir of Urology. So it's nice to have you both in the same hall. It's a little bit different presentation. It's about change. But Professor Ahmed Ali saved me something because he talked a lot about change. Not only Professor Ahmed Ali, but everybody talks about change. Nobody would say no to this if you talk about change. And no one would defend the status quo. But what to change, how to change, and who will lead and manage the change. There are many reasons for change because there are clear defects that need repair, and we have comparative defects when we compare our institution to other institutions, and when we compare our department with other departments. There are changing needs of students, of patients, of staff, of the administration, of all stakeholders. There is cultural change. What was accepted yesterday is not accepted today, and certainly not tomorrow. And of course, we have ambitions. What are the types of change? There are different models that talk about different types of change. This model talks about two types of change: adaptive change, which is change in response to challenges, and transformational change, which is change before we have challenges. In this model, we have four types of change: incremental anticipatory change, which is change before the system is challenged, and incremental reactive change, which occurs in a response to a shift in the external environment. We have radical anticipatory change, and we have radical reactive change. There are other models. In this model, there are 5 types of change. In this model, there are 6 types of change. This model classifies change into 12 types of change. In this book, it's an interesting book because it's about the new science of medicine and management. There are different case studies of change. There is a lot to read and to find about the type of change and the management of change. This is one case. It was conducted in the Department of Surgery, Children's of Alabama Hospital. They initiated a project. It started with interviews asking the staff, how can I help you to do your job better? And please explain from your point of view how management make decisions, how policy decisions are communicated, how disputes are handled. And they constructed a relational coordination map. What did they find out? They found that they have a dysfunctional surgical culture. There are work groups in the OR. Hospital administration has its policies. Nurses and staff have their way of conducting things in the OR. The anesthesia and surgeons, they have different perspectives on how to run the OR. So there was a combative environment, and there was lack of collaboration between surgeons and everybody. So they analyzed the current state versus the desired state. I will stop to welcome our Dean, Professor Ali Al-Anwar. They found that they had a state of untimely and frequent communication problem with a blaming culture. The nurses were afraid of being in the middle and being blamed for any failures. The surgeons and other stakeholders tend to isolate into their silos, feeling that they lack control and autonomy in the OR. They defined the desired state. We need to find shared values and mutual respect, and we need to create a system where communication is frequent, accessible, and done in a safe place, devoid, or a safe space, devoid of harmful power dynamics. And we need to create a boundary spanner to help close the relational gap and build trust and break down silos. So they assigned a physician of the day or leader of the day. They found out that the surgical culture rose organically or spontaneously without intentional design. And their experience manifested infrequent and inadequate communication and a lack of clear leadership, which resulted in a battle of wills between surgeons, nurses, the staff, the administration, and sometimes the anesthesia staff. All these factors caused frustration and negatively affected workflow. So they needed a leader, coordinator, who acts as a boundary spanner to implement the administration's policies and facilitate workflow through communication among work groups. In the same book, Tracy suggests a plan for transition and transformation. It starts with analyzing the current structure, with situational awareness, setting clear goals and expectations, and position critical figures and teams of influence, communicate effectively, and each change needs to build partnerships, to build teams, and deal with broken relationships, either remove or repair, activate networks, and engage stakeholders. The UK NHS proposes a change model that's composed of 8 components: shared purpose, leadership, motivation and mobilization, system drivers, measurement, project management, improvement tools, spread and adoption. They found out that leadership is crucial. The achievements, good practice, and learning from what works and what doesn't work should be shared within organizations and across organizations. And since some elements of each change program are not under our control, we need to share and learn from our experience and others' experience. And even learning from experience needs to be planned. They propose an improvement approach which consists of 5 steps. Preparation, launch, diagnosis of the current process, implementation with the known cycle of plan, do, check and act, and the evaluation of outcomes. Achievements are celebrated, experiences and principles are captured, and the improvement becomes the norm. They propose a leadership model which consists of 9 dimensions: sharing the vision, inspiring shared purpose, leading with care, evaluating information, connecting the services and engaging the team, and holding everybody accountable, developing capabilities, and influencing for results. Energy is the fuel of high performance, not time and no resources, and not resources. And we have 5 domains of energy for change: social energy, spiritual energy, physical energy, intellectual energy, and psychological energy. This is an important survey because they found that only 13% of employees worldwide are engaged at work and psychologically committed to their jobs, while the majority are at best just compliant. A leader needs to understand the response of the employees to change. There are generally 4 responses. There are people who will actively resist change, people who will disengage because they don't agree to change, and there are people who are proactively endorsing change, and there are people who just accept and become compliant. And the leader needs a plan to overcome resistance to change. It starts with education and communication, encourage participation and involvement, assume the role of facilitation and support, manipulates and co-optate people, negotiate and bargain, and eventually apply explicit and implicit coercion. So this is another model for resistance overcome, which can be applied by a healthcare leader. It starts with preparation, explain why change is important, create dissatisfaction with the status quo, reduce uncertainty, and then lead. Lead by providing an inspiring vision, setting milestones, giving people the energy, and communicate. And then involve the people by empowering other leaders, reward adapters, and celebrate victories. So the take-home message is that change is inevitable. It's better be planned. Leadership is crucial. There will be resistance to change, and leadership needs to find the best way to overcome the resistance. Thank you.
Yes.
Dr. Tamer.
Morning, my name Professor Tamer Borg, Professor Obigaini. So I'm a guest here in this room, but in the end of the day, we are all surgeons, so we are all children of a general surgery department here. Thanks, Professor Mohi, for a brilliant, very brilliant presentation and a brilliant demonstration. In your presentation, you mentioned around 6 times the role of the team. And I want to know, what is your vision about the implementation of a multidisciplinary team in Ain Shams University? Because we all know that last week we were conducting a very successful workshop in Ain Shams University about laparoscopic surgery. And the main star of this conference was the teamwork, and how can we add to each other, and how can we cooperate with each other. And also 9 times you mentioned the leadership. And I want to make use of the presence of our esteemed Dean, Professor Dr. Ali Al-Anwar, say how can the leadership direct a multidisciplinary team in Ain Shams University, that we can all work together, not as separate hospitals?
I think we are in the age of multidisciplinary management, especially in the age of specialization. We do not have a surgeon who can perform every type of procedure with the same proficiency. And now we have patients, and the patients don't come with one disease. Sometimes they come with multiple pathologies. And there are certain diseases that need multidisciplinary teams. Like the coming session now, you will be talking about endometriosis. And I know that there is a great collaboration between the departments of gynecology and Department of General Surgery in managing these cases. So yes, we need multidisciplinary teams. We need teams even within the domain of general surgery, because now even the general surgeon would need a colorectal surgeon to assist in certain cases. We have a great collaboration between the hepatobiliary surgery team and the colorectal team when they have a patient with liver metastasis, colorectal cancer with liver metastasis. We had 2 cases last week, so it's essential to have multidisciplinary team. Building a multidisciplinary team is really not easy. But I think that we have a great model of leadership now, which is different than the leadership that we had in the past. Because in the past, there was the ego that would prevent a general surgeon to accept a gynecologist to tell him what to do, when to come and participate in the management of a certain case. I think leaders of today are different in Egypt. They can take a step behind and let others do what they think must be done. So the most important thing is to have a shared vision, a shared purpose. And we need to work together for the results, for the best outcome. And we accept, the leader now accepts to take a step back and let others perform and implement the shared vision. We need wise leaders to lead multidisciplinary teams. We need understanding from both sides or from many sides in order to lead successfully such a multidisciplinary team. But I think it's the future. And as I said, already we can see a change in our institution and other institutions, and we will see more changes in the future, and it's better to plan the change. It's much better than we find the whole environment is changing without changing our concepts and our mind. Thank you very much.
Thank you so much, Professor Wahi. I know, Dr. Amr, that we are running late and behind the schedule, so we'll move to the last lecture of this session.
Yes, our next presentation is by Assistant Professor Dina Harley on women in surgery.
First of all, I want to thank Professor Dr. Mohi Banna for giving me the chance to present here in this conference, and I'd like to thank all of the presence here. It's a great pleasure to meet you, Professor Tyler, and of course, Professor Dr. Hassan Shakir. This is great for me. My talk today will be a little bit different. It's about women in surgery, Ain Shams experience. The history says that women have been involved in surgical practice since ancient times, about 3,500 years before century, ancient Egyptian women would do surgeries. But I searched the AI. I wanted to take help from the Copilot and the ChatGPT to help me in this presentation, actually. But I was astonished by what I see. First, the whole issue about women in surgery can be collected in 3 points: that they have challenges and barriers in entry, they have discrimination, and social expectations from women are a little bit more than men. I read that the first surgeon in the USA, I think she was called Dr. James, she disguised in a man to work as a surgeon. And so I intended to come with a dress today and define myself as a female surgeon to show you that now there is a great difference between what was in the past and what's coming now in Egypt, at least in our Ain Shams University. So, if the society and male surgeons are against female surgeons, then who taught the first female surgeon? Of course, there were challenges before, yet now we have so many male surgeons who are helping females, of course. Why surgery is important for females? Most of us became surgeons because we love surgery. Surgery is our patient. We feel satisfied to see the results of surgery after we do it. Yet some female surgeons get it as a job for better financial life, because in our society, female patients prefer to go to a female surgeon, especially in breast and anal diseases. And this is, so this is worthy financial, this is part. And this applies not only for Muslims, even Christians. All females in our society wants a female surgeon. Ain Shams University, the first female surgeon started to enter the department. This was about 20 years ago. She is Professor Dr. Rania Al-Ahmadi, and now the number of female surgeons is around, staff surgeons is about 10, and the junior doctors are the same, about 10 female juniors. Do women really face challenges in surgery? We can't deny that surgery is a stressful job. Whether the surgeon is a male or female, it is stressful. We can't deny this. So what a man faces, a woman faces. But of course, the emotional state of a woman makes the feeling of stress much more. How our senior staff treated us. Anyone can't ignore that he or she always contacts good and bad people. The same goes for surgery. So we have some aggressive staff, of course, who don't want women as surgeons, and also we have good cooperative staff who helped us as female surgeons. And so we are grateful for this, and I will show how they helped us in different ways, not only in surgery. Before this, I want to get on also a point how we female surgeons treat our junior staff, whether they are males or females. Actually, I want to say that we are angels, but this can't apply. Stressful conditions and emergencies make us tough to some extent during work. So we as males are good surgeons, of course, yet as teachers we are good and some are not cooperative with their junior staff. We are both good and not bad, but not cooperative to some extent. At last, we are human, we can't be good all the time, and we are also never bad all the time, yet all of us are trying to do our best. The support we had, actually we had support first of all in the learning part, learning surgery. This is the biggest support one can have as a surgeon, actually. Doing operations, entering the theater for the first time, this was all helped by our professors. Support in promotions and the exams, actually we don't have any bias, our professors don't have any bias for male surgeons to become better than females or something like that. Encouraging us to announce about ourselves through media. This was a TV program. Professor Dr. Ahmed Abdelaziz, the head of General Surgery Department 7 years ago, he chose 4 female surgeons to talk about their career in the TV. To show that Egyptian female surgeons are competent and they are staff members in the university and they can do surgeries. They helped us to go to rural areas and express ourselves. This was a photo from a caravan, medical caravan in Halayb and Shalatin triangle. And this actually was a fun day inside the medical caravan. So they encouraged us to go and help poor people. This is another way of support. Professor Dr. Magdi Basyouni invited us to share in the talk in a conference with the Royal College of Surgeons in the Saudi Al-Mani Hospital, and he invited female surgeons to present themselves. There is also support in new jobs and social life. Actually, Professor Dr. Mohi Al-Banna gave me the chance to be the head of General Surgery Department in a private university. And actually, you know that to be the head of General Surgery Department in a university, this is a big issue for us, especially if you are a female and leading a large number of males. Our relation as female surgeons outside the work, we are actually friends outside the work, even inside. This is also our relation outside the work as females and male surgeons. Our social life, some of us are married, some are single, having our personal life lived as we can to the max. Having fun from time to time. So that surgery doesn't affect our social life. The take-home message that I want to say is that, of course, surgery affects life of surgeons, yet this is for both males and females. There is always fun in surgery, and there is always time to live your life. History is always written by winners. Maybe females entering surgery for the first time, they had so many challenges, but now we have to change this history that females, at least in our community, are taking a great role and not only their rights. I think now males want support more than women in Egypt. I think this. So this all that I can say about women in surgery. Thank you so much.
Thank you, Dean. I want to assure you that the look has been changed drastically throughout the last 20 years, and be sure that not only the senior male surgeons trust the females, the look of the society or from the patient side has been changed, and they trust. So be sure that you are trusted, and I'm afraid that the day will come that the surgical department, the majority will be female surgeons rather than
our junior doctors are all females.
By the way, Rania was the first to continue the residency program. to the persistent. But before her, there were few trials by females that they couldn't continue. They just spent a few months and they failed to continue the residency program. And before Rania, in the plastic surgery, I think was in Ines. In the Ines senior and Rania, she is a plastic surgeon, the first female plastic surgeon in Shams University. So be sure that we all trust you.
Thank you so much.
You are a very good and good look of the surgical department in Shams University. Thank you.
Thank you, Dr. Hassan.
And now I'd like to invite Professor Ali Al-Anwar, Dean of the Faculty of Medicine, and Professor Amr Al-Husseini, coordinator of the conference. We are very pleased and honored by the presence of Professor Tyler Hughes. It's our pleasure to present the plaque of the Department of General Surgery and of Ain Shams University.